Almost done, guys. Just give it a minute for everyone to get on.
Everyone, we had a dislocated elbow yesterday. My 17-year-old girl at my clinical.
Oh, good.
They gave her 100 of fentanyl. Uh, what was it? 10 of Versed, and they gave her 10 of etomidate. She would not go down. She was still fighting the whole time.
When they were trying to reduce it.
Yeah.
What? Yeah. So.
It seemed excessive.
Well, it's just sometimes with sedation, what you commonly use to create the sedation, right? The amnesia, you know what I mean? Like the anesthetic effect. Depending upon the size of the individual, depending upon their pain level, right? The amount of catecholamines their body is producing and releasing, it can influence, how much it takes to sedate, which is, I'm surprised they didn't use ketamine right out the gate as for an anesthetic dose of ketamine, especially in a child. Their sense of imagination is so wide and vast. It tends to be one of the most common uses in ketamine is with sedation in children. But yeah, sometimes that happens, man. It just, they're trying to create, I don't know why they went with fentanyl, and I don't know why they worked in that progression, but a lot of times it's just by what the physician is comfortable with.
Yeah, the girl's just still fighting and still like with it until like the very end. And then she kind of like, yeah, she finally, like relaxed, but her elbow it was like twisted and dislocated at the same time. It was weird. It was like off to the side. I wish I took a picture of the x-ray. It was like off to the side. The bone, I've never seen anything like it.
Hey, Barrett's not going to be back on. He's going to an ASMAT call.
Okay. Remember, guys, when we're using neuromuscular blocking, right? Once we give that paralytic, the patient is now apneic, and they will lose the ability to protect their own airway, right? So once we administer a paralytic, which is never going to be solely administered, right? We're always administering a paralytic with an induction agent being given first to create that sedation or disassociation. But once we push that paralytic, we now took a breathing patient with a semi-marginal or patent airway to an apneic patient that has no airway until we provide it for them. Your paralytic medications, right? They work at the neuromuscular junction, right? Relaxing the muscle and impeding additional acetylcholine from creating muscular contraction. The difference between your paralytics that are depolarizing and non-depolarizing, your depolarizing paralytics occupy that neuromuscular junction and push out the acetylcholine, which produces that contraction or that fasciculation, where your non-depolarizing encapsulate that acetylcholine at the neuromuscular junction, preventing further movement of acetylcholine that produces the paralysis. Apneic oxygenation, right? That's the theory that by placing high flow via nasal cannula, right, the high flow helps to push the high FiO2 down to the alveoli without the expansion and contraction of the diaphragm and the thoracic cavity. So essentially it's apneic in the sense where there's no ventilation taking place, but there is that high FiO2 being pushed down with the high liter per minute flow down into the alveoli to allow for gas exchange. differences with delayed sequence versus rapid sequence intubation, right? The whole purpose of a delayed sequence intubation, we are administering a induction or a sedative 2 minutes before our paralytic to allow for that period of oxygenation to take place before I push that paralytic and produce apnea, right? So a delayed sequence intubation is to allow for that oxygenation period prior to the administering of your paralytic. If I use succinylcholine, right, and I don't want the patient to experience fasciculations or the subsequent bradycardia, I can give 10% of a non-depolarizing paralytic first, right? So I can preload my succinylcholine, I can pre-dose my succinylcholine with rocuronium or vecuronium at a 10% dose. So I'd give 10% of what I would give in a full dose of rock or vec, followed by the normal dose of succinylcholine, which would be your 1 milligram per kilogram.
Why would you do that?
It helps to prevent the fasciculation. It's not a common procedure. It's kind of extinct. We don't generally consider it. It's probably something you'll never see, but it's still an option to prevent fasciculations. What you will see was with pediatrics, before we give sucks, we're going to give atropine to prevent the subsequent bradycardia, because succinylcholine pushes out all the acetylcholine from the neuromuscular junctions. So you tend to see right after succinylcholine is pushed, you'll see the fasciculations, and you'll watch that heart rate drop way down. And as soon as it drops way down, it builds back up. So in children, they can't tolerate that drop in blood pressure, especially if they're hypotensive already. So I'll give them atropine to inhibit the acetylcholine from affecting the myocardium, right?
But why would you mix a polarizing with a depolarizing? Don't they work differently?
They do, which is in the event that you do not want the fasciculations that come secondary to your succinylcholine, right?
Okay.
You can consider giving a 10% dose of a non-depolarizing paralytic prior to giving the succinylcholine. And its sole purpose of that is to prevent the fasciculations that's caused by the succinylcholine. So let's say you've got a spinal cord injury patient, you don't want them to fasciculate. You can give them a 10% dose of a non-depolarizing paralytic. And the reason why you would do that is your non-depolarizing paralytics, they have longer half-lives. So I don't want the half-life of that non-depolarizing paralytic. I want the short half-life of that succinylcholine. But I want the advantages of that non-depolarizing paralytic in the sense where it'll prevent the fasciculation. So I'm going to give you a very, very small dose of that non-depolarizing paralytic to prevent the fasciculations. I'm going to obtain the paralysis through the use of that short half-life with succinylcholine. One of the adverse events of CPAP is hypotension, right? Because it increases the intrathoracic pressure, which can then inhibit or compress your inferior vena cava and in return produce some hypotension. It's not common, to be honest. Even if my patient is borderline hypotensive and they're having some type of cardiogenic shock that's producing pulmonary edema, I still will consider CPAP to help push that fluid down and create better oxygenation. But I'll be hypervigilant and I'll watch my blood pressure to ensure I don't see that transient or non-transient change or drop in blood pressure. The hepatojugular reflex, right? That's secondary to excessive fluid retention. And being that there's so much fluid moving through the liver at any given moment, if I inhibit or slow the blood movement through the liver, I immediately will create backflow. So if I have somebody that, you know, has excessive fluid or is having right ventricular heart failure where I'm having a tough time circulating that blood, if I push down on that liver and compress that liver and further inhibit blood flow through that liver, I will see my jugular vein begin to expand. That is what we know as the hepatojugular reflex. That is indicated or indicative of heart failure patients or patients with fluid overload. Remember, with COPD patients, we commonly see exacerbation during the changes of the season, right? High pollen counts and things like that. Most of the time, because of the drier air or the colder air, we tend to see, you know, the turbulent movement through the inflamed airways, which exacerbates their COPD. With your pulse oximeter, when the patient is starting to become hypoxic, right? Remember, it's a little delayed. So when you start to see your saturations drop, they're actually a little bit lower than what you see. The trend is a little behind. So that changes when they start to become really hypoxic. When their saturations start to get, you know, into the 70s and 60s, you'll see that desaturation a lot faster than when they started to desat. So the lower their saturations, the faster that number will drop unless we fix it. The higher their saturations, the trend is a little bit behind, and the slower the number will drop. All right, we gotta change gears here a little bit. Talking about where the movement of oxygen and CO2 take place. So let's see here. you have internal versus external respiration. So your external respiration is the movement of gases at the alveoli in your lungs. Your internal respiration, that is the respiration that takes place at your tissue, right? Your aerobic metabolism at the cells. So when we're talking about the movement of oxygen, if we're talking about the movement of oxygen within the lungs, we're talking about external respiration, which is produced by the external environment, right? The oxygen coming from the external environment down to the lungs. Internal respirations, now that oxygen is already in the body, it moves to the tissue, and it's moving within the cells within the tissue. So external in lungs, internal cells of the tissue. Remember, there's things that can produce false pulse oximetry. One of the most common reasons that we see is the carboxyhemoglobin levels, right? Which is your what? Anybody know?
Isn't that nail polish or no?
Nope.
Like what's the numbers
Carbon
or
monoxide.
what can cause it?
What produces carboxyhemoglobin?
Carbon monoxide or cyanide.
Hypothermia?
I'm hearing a lot of different things here.
CO poisoning.
So your carbon monoxide is what produces your carboxyhemoglobin, which is the amount of CO that is attached or has the affinity to your hemoglobin. Like I said, your pulse oximeter does not have the ability to differentiate what type of gas is attaching to the hemoglobin. All it has the ability is to see that there is a gas, saturated against that hemoglobin. So when we do have the ability to not measure the carboxyhemoglobin level through our rainbow monitor, right? It can give us the carboxyhemoglobin level through, just like our pulse oximeter gives us a percentage. Anything above 10, we start thinking about management of the carbon monoxide, which is through high FiO2, PEEP, and if need be, hyperbaric treatment. Differentiating a cardiac tamponade versus a tension pneumo, right? They're both going to change blood pressure. They're both going to produce, JVD. But one of the biggest differentials between a cardiac tamponade and a tension pneumo is when we oscillate their lung sounds, clear and equal lung sounds is definitely not going to be present in a pneumo, because we should have absent lung sounds on one side. Cardiac tamponade is strictly in relation to the myocardium, in the tamponade around the myocardium by the pericardial sac becoming inflamed and compressing the myocardium. So that cardiac tamponade will have clear and equal lung sounds versus your tension pneumo, you're going to have absent lung sounds on one side.
That one falls under that obstructive shock.
Correct.
So would both of those be considered obstructive shock?
Yes.
I know the cardiac one is the tamponade, but
A tension pneumothorax, a tension hemopneumothorax, or both can be under a obstructive shock. Yes.
okay.
What's the antidote for a cardizem overdose?
It's a calcium channel blocker, so you need to speed up the conduction going down through. So you need something to open that up. I don't remember what it is.
If I have a calcium channel blocker overdose, I'll give it what I'm blocking. I'll give them excessive amounts of calcium, right? So I can give them calcium chloride, calcium gluconate. Calcium chloride tends to be a better option because calcium chloride contains 4 times the amount of calcium ions in relation to calcium gluconate. That is the primary difference between calcium chloride and calcium gluconate. They both are considered electrolytes because it contains calcium. Obviously, gluconate being that it's going to have some glucose in it. But the big issue with calcium is it can be necrotic, which is why calcium gluconate can be considered, especially if you're dealing with peripheral access issues. But calcium chloride is a more potent calcium medication because it contains 4 times the amount of calcium ions.
I'd have to look it up, but a calcium channel blocker, it blocks a channel and we just raise the calcium. If the channel is blocked, why would we be able to make it through?
We're essentially going to flood the gates.
Okay.
We'll increase the calcium serum levels to the point where it becomes effective, although they've got a calcium channel blocker on board. Remember, the further away you go from your SA node, the slower the intrinsic rate gets. Your left main coronary artery, your right coronary artery, your left main coronary bifurcates into your left anterior descending and your circumflex. Remember your anatomy. Remember where those coronary arteries perfuse in relation to the tissue. Does it perfuse the inferior wall? Does it perfuse the high lateral, low lateral, septal anterior? Right? Just remember the anatomy of your heart. Negative versus positive pressure ventilation. Negative pressure ventilation, that's normal ventilation that's produced by contraction of the diaphragm and contraction of your intercostal muscles to expand your thoracic cavity, producing a negative intrathoracic pressure. Your positive pressure ventilation, that's what we provide, right, through creating a seal with a bag valve mask or through when a patient's on a ventilator, we're pushing air down into the space, creating positive pressure versus, a patient breathing on their own, producing negative pressure. Remember we're talking about COPDers, what emphysema is. Emphysema is essentially the destruction of the alveoli walls, which is what produces that chronic tachypnea. All right, that's all she wrote. You guys got 4.5 hours of my time. Hopefully it was worth it.
Thank you.
Thank you. It was.
So between now and Tuesday, right? Let's keep grinding, guys. Do not let your foot off the gas pedal. Let's just make sure this is a sure thing, and let's crush this test. All right, we've got to crush this test. You crush this test, that's a massive weight off your shoulders. And like I said, the back 9 of this course is substantially slower and easier than the front 9. Unless you put yourself in a position with this midterm where it's make or break on every single exam, which I promise you, you've got a lot more FISDAP exams ahead of you. You don't want that to be your situation. So let's come into this test prepared. With the study guide, as well as the 4.5 hours that I just spent with you guys. I mean, you'll be given more than enough resources to do well. It's just a matter of you taking those resources and putting them in play now. If you've got any questions, feel free to reach out, shoot me an email on any concepts you want to clear up or any last minute type situations you need assistance with, and we'll handle it case by case basis. All right?
Hey, really quick, the practice test, I have not taken it yet.
Okay.
I'm still studying. Is that like a one and done, or can we take it multiple times?
It's open for multiple attempts. Yeah. It's meant for you guys to just reference check yourselves, right? I wouldn't wait to the very last minute to take it, just in case you see some areas that you need to work on. I would say probably around now, and for Friday is a good time to take it. So you've got the next few days to fine tune and advocate time appropriately. So, but yeah, you can take it as many times as you need. All right, guys, I'm logging off. Enjoy.
Thank you.
Cool. Does anyone else's
you.
counter look like this?
Yep.
I got shit everywhere. Thanks, Blum. Thanks.